This morning, we have Dr. Wetterhahn here to present Grand Rounds. She is one of our fourth-year residents in the rural track, as many of you know. She did complete her MD and MPH from Tufts University prior to arriving here at UW. She is a National Health Service Corps scholar and will start her service commitment in Coconino County, thank you, Arizona, after graduation. Please join me in welcoming her this morning.
Hi, thank you for coming to my Grand Rounds, More Than OSH, Why Outside Hospitals Transfer Patients and How You Can Help. The objectives of my Grand Rounds are to discuss challenges faced by rural providers and patients both during the transfer process and more generally, to discuss the frequency of maternal transfers to Meritor, the most common reasons for transfer, and why transfer requests are rejected. And then finally, to examine an example transfer case from different perspectives. After that, we'll have an open panel discussion. But to do that, I've invited a panel of rural generalist OBGYNs to share their experiences and perspectives. Two are here in person and one is attending virtually. And I'm very grateful to all of them for sharing their morning with us. First, we have Dr. Scott Hansfield. You might recognize him from various stories about the rural residency program, as pictured. He attended Northwestern for medical school and went to Rush for residency. He practiced in the Chicago area for 8 years, including at a residency program. During this time, he was the chair of the OB department at Highland Park, which had 2,500 deliveries a year, and subsequently was the vice chair of OB at Evanston Northwestern, which had 4,000 deliveries a year. He then had what he described as a midlife crisis, his words, not mine, which led him and his family to Waupun, a 25-bed hospital with 165 deliveries a year, where he has hosted us as rural residents. And there you are. Next, we have Dr. Effie Siomos. She attended the University of Wisconsin for both medical school and residency. She's worked in 2 private practices at rural sites over the past 13 years, doing bread and butter OBGYN. In addition, she's currently the medical director for obstetrics and starting a physician peer support program at Theta Care. She's grateful for the outstanding support from her spouse, dogs, and teenagers, in that order. That was also a direct quote. Last attending virtually, we have Dr. Christine Troutman. She attended the University of Wisconsin for medical school, graduated in 2008, and then also completed her residency here, graduating this program in 2012. Dr. Troutman has worked in Texas for several years before returning to Wisconsin. Her professional interests include rural health care and patient advocacy. Her personal interests include raising and showing horses. In fact, I think she's taking some time out of her vacation, showing her horses to join us this morning. So, as we all know, transfers happen. Sometimes they happen at convenient times and sometimes they don't. And no one has more to say about that than us residents. When they happen isn't controllable, but how we manage them is. For those of you not familiar with Dr. Glaucom Fecken, he is a very popular medical comedian and real-life ophthalmologist who relatively kindly satirizes different aspects of the US healthcare system and different specialties. So while the next clip, titled Rural Medicine Transfers a Patient, seems like a comedy, I do think it's a good opener as it hits on some real truths regarding transfers, why they happen, and how to best manage the process. Maybe it just is taking.
This is surgery. I was paged. Jim Bob, you need a hip replacement. I don't care how much scrap metal you have in your barn. You need to go to the hospital. You need to see an orthopedic surgeon. Hey, I'm really sorry about that. I was paged. Yeah, I got an 80-year-old with acute cholecystitis. He was having biliary colic episodes back in July. Now he's got a fever, leukocytosis. I need to transfer him to the university for surgery. Why didn't he get surgery back in July? During corn detasseling season? God himself couldn't make this guy have surgery back in July. You don't have a surgeon out there, and where are you? We don't have a name for it. It's unincorporated land. Hey, Tom. Yeah, boss. Were you able to get a hold of that general surgeon down in Brookfield? Oh, yeah. No, he only operates on horses now. Oh, man. No, we don't have anybody. All right. Can you send over some chart notes? Oh, sure. Hey, Peggy. Fire up the fax machine. Just send it electronically. Epic has interoperability with most systems. We'll interface through PACS and you can push everything through the health portal. Hey, Peggy, you got the fax going yet? Hey, boss, Darlene is here. She's going into labor. Yeah, okay. Give me a second. She says she doesn't want to be a bother. Tell her I'll be there in 2 minutes. All right, just tell me what you saw on the ultrasound. Oh, we don't have one of those. You don't have an ultrasound? Nah, we sold it to help pay for a CT scanner. Okay, well, what did the CT scan show? Not much. We ran out of contrast. You don't have any contrast? Well, Texaco Mike is cooking up a batch, but it's gonna be a while. It's not something you want to rush. So you want to send a patient 200 miles for surgery without any imaging? Yes, that's right. Outside hospitals. It's always the same with you guys. Huh. You're not happy with the level of care we have out here in the rural community? No, it's substandard. Hey, let me ask you, how many partners do you have? I have 7 partners. Why do you ask? Oh, well, maybe instead of being the 8th surgeon at a quaternary care medical center, you can come out here and help us. That's what I thought. So me, Texaco Mike, and the gang will continue doing our jobs to the best of our ability with the resources we have, and you can help us when we need it. Yeah, okay. Hey, boss, Darlene says never mind. It's her 5th kid. She said she'll just do it herself. What? This is surgery. I was paged.
Please stop. All right, we're trying to get out of this. The screen seems frozen. This wasn't a great clip, but I don't think we need to watch it again. Last time I escaped it. Did it again. There we go. Perfect. Okay. We did it. Okay. Thank you. So, while not specific to obstetrics until the end, that clip does touch on some of the distinguishing characteristics of different levels of care that determine where patients are best served, such as specialist availability and imaging availability. ACOG and the Joint Commission have created definitions for different levels of maternal care, which many hospitals report. They don't, however, offer a definition for the first level of care, an accredited birth center, and directs readers to the American Association of Birth Centers Standards for Birth Care Centers document. Moving on to level 1, described as basic care. These facilities have a capability to manage low to moderate risk pregnancies, provided they have the ability to diagnose and manage unexpected maternal or fetal conditions as they arise and prepare for transfer as soon as that is possible. Level 2, or specialty care, includes the capabilities of level 1 plus management of moderate to higher risk antepartum, interpartum, and postpartum patients. Level 3 similarly includes what can be managed at lower level institutions, with the distinction that more high risk conditions can be managed there. This is different from level 4, which is a regional perinatal health center, which also have on-site medical and surgical care for the most complex maternal and fetal concerns. That doesn't mean an awful lot to me when I read it. And so I think more helpfully, ACOG offers examples of what kind of conditions could, pending provider comfort, be managed at each of the kind of following levels of care. So they say essentially only like uncomplicated vertex singletons at term being managed at accredited birth centers, if that's the patient's choice. For level 1 centers, they can manage uncomplicated twins, tolax or preeclampsia, with a cutout that if preeclampsia with severe features evolves, then they may need to transfer pending the provider's comfort and available resources. Level 2 centers can manage what are anticipated to be complex C-sections. Placenta previa without any prior uterine surgery, in other words, lower risk for having a percreta or accreta. They can manage pregestational diabetes or poorly controlled comorbid conditions like asthma or high blood pressure. Level 3 institutions can manage a suspected percreta, AFLP, expectant management of preeclampsia with severe features not moving towards delivery, or moderate cardiac disease. Last, the highest level of care, a level 4 center, can manage severe cardiac disease or severe pulmonary hypertension, patients who are anticipating needing a transplant or are likely to become neurosurgical or cardiac surgery candidates. Similarly, there are neonatal levels of care, and that's another reason why OB patients are often transferred to ensure the right level of neonatal care after delivery. The first level is a well-born nursery. The second level is a special care nursery. The third level is a neonatal ICU or NICU, and then the highest level is a regional NICU. A level 1 NICU can manage essentially well-born babies born after 35 weeks who are otherwise stable. Level 2 can provide care for infants born after 32 weeks and have an estimated fetal weight of at least 1,500 grams, who may have issues related to prematurity but don't have other comorbid conditions. They can also provide mechanical ventilation, but only for less than 24 hours. If additional life support is needed, then they need to be transferred to a level 3 center that can provide the sustained life support. They can manage neonates born at under 32 weeks and with an EFW of less than 1,500. And finally, a level 4 NICU is located within an institution that has on-site available surgical specialties that may arise for any kind of congenital or acquired conditions. For reference, Meritor is a level 3 NICU, but AFCH is level 4 NICU. So honing in on Meritor specifically, I asked our perinatal administrators for information on where we most commonly receive transfers from. You can see the wide geographic distribution here. The numerals to the right indicate the maternal and neonatal level of care available at that site. Maternal is first and neonatal is second. As I mentioned before, not all hospitals report this, and so it's not available for everybody. And finally, Meritor. Last year, 4,893 infants were delivered here, making it the busiest LND in Wisconsin. The LND was expanded in 2017 with a new triage area pictured here. You can see the caption identifies one of our former rural residents, Dr. Alexa Lowry, and another unidentified fellow resident. Other recent changes include an in-house hospitalist program. I already talked about the levels of care available here. In the past year, the most common reasons for transfer to Meritor were preterm labor, PPROM, preeclampsia or HELP syndrome, bleeding in pregnancy, and placenta accreta spectrum. Meritor averages about 50 transfers a quarter, which works out to a little more than 1 transfer every other day. If you thought that you were just imagining there being more transfers at the end of June, it turns out that wasn't your imagination. It really was busier then. On the other hand, Meritor does deny about 5 transfers a quarter, or about 1 every 2 to 3 weeks. One common point of confusion is the term close maternal transfer. I think we all hear that a lot during rounds and then nevertheless have a patient arrive. And so I think this is a good time to kind of clear up why that happens. Usually the status indicates that the NICU is closed or the L&D is too busy. This is something of a misnomer, however, because due to EMTALA laws, even when Meritor is closed to maternal transfers, there's still a legal obligation to take patients who are in an outside ED or OB triage area, in other words, not admitted to an outside hospital. This is in contrast to inpatient transfers, as EMTALA does not apply to these patients. This is the algorithm that the Access Center actually uses to triage these calls. You can see that there's one other carve out, and it's for patients who have already established care with us. Since we are their delivering hospital, they are also able to come. All right. So for the last part of the talk before the discussion panel, I wanted to talk about an example kind of transfer case. I'll be asking for people's perspectives on the case afterwards, so keep that in mind as you're listening. A provider at a referring rural hospital calls to request a transfer of a 36-year-old G2P0101 at 31 and 5 who presented to their triage for acute vaginal bleeding after a fall on ice. Her pregnancy is complicated by a known chronic abruption, a history of a spontaneous preterm delivery at 36 and 0 that was complicated by a retained placenta requiring D&C and transfusion. Her cervix has changed from 1 to 2 centimeters at this hospital, and her EBL so far is 300. Her coags are normal. She's been given betamethasone and started on magnesium, which she initially expressed she might decline due to the fluid and food restrictions. However, after a lot of counseling by her primary OB on the importance of magnesium for fetal neuroprotection, she ultimately agreed. She arrives to Meritor via ambulance. She has no bleeding en route and is still 2 centimeters on her 6-hour recheck. She is transferred to antepartum, and while being moved there, she overhears a conversation between 2 residents about her transfer being, quote, a whole lot of nothing, unquote. The next morning, the residents lets her know that they are discontinuing her magnesium as she hasn't made any more change and her bleeding has stopped. She doesn't say anything, but she's upset since her home OB told her how important the magnesium was. In fact, they talked about it for at least half an hour because she really wanted to eat. She isn't sure who's right, but it does seem like someone doesn't know what they're doing. She asks if she'll get another dose of betamethasone, and the resident says, yeah, since you already got started on it, we normally finish the course. It seems from that comment that this doctor doesn't necessarily agree with the decisions that her home OB made, and she starts to wonder if her initial management wasn't right. 2 days later, she still has no bleeding, so her team starts discussing transfer home with her. She's anxious about going home since she's not sure about the quality of care she'll get there. She has had a lot of thoughts about what went right and what went wrong, and it seems like a lot of changes happened that she didn't anticipate, and she doesn't really know how to put those in context. She wonders to herself if next time she bleeds, if she should just drive herself to Meritor. So one takeaway I had from this experience after discussing it with the patient, who ultimately kind of brought some of these concerns up to me, after emphasizing, of course, that she should definitely go to her local hospital if she's bleeding, is that sometimes by virtue of being an academic hospital, patients can kind of attribute a lot more significance to what you say, even if your years, or I guess in my case, the same months of training don't really support that level of trust. Not to say that's always the case. Patients sometimes, we can make recommendations about things we think are best for them, but they're not really part of the plan until they talk to their home OB. But I think it's worth sometimes keeping in mind that patients can either overhear things we're talking about or interpret them in certain ways. And we have to be careful not to undermine any kind of aspect of the patient's relationship with either us or with their primary OB, even if it's completely unintentional. So I'm interested to hear what other people's perspectives are on this transfer. I'm wondering, maybe starting with the residents, if any of you guys have any ideas on what factors might have led to this patient to be transferred. Haley.
I think the fact that she was 31 and 2 weeks with a history of a preterm delivery and actively bleeding in a setting that doesn't have the support for the baby if delivery does happen, was probably what initiated the transfer, because from a maternal standpoint, she seemed pretty stable, but then it was the questionable delivery timing that probably drove the transfer.
A couple other factors for this patient too was that the hospital she was coming from didn't actually have any blood in the blood bank. They normally had 1 to 2 units of packed red blood cells, but this was kind of during early COVID times and blood was pretty scarce. So they actually had 0 blood in the blood bank. And given she had a history of a DNC and needing a transfusion and had a chronic abruption, they were concerned that that was going to become something that she needed. You're right. It was mostly the gestational age that was kind of the driving factor. But a couple other things that can sometimes come into play. We're very lucky here to have overnight anesthesia in-house. A lot of hospitals don't have that. They have to be able to respond within 30 minutes, but that's actually a pretty significant luxury that we have. And sometimes, honestly, it's like nursing staff. Obviously, the pandemic has caused a huge nursing shortage across the country. In rural areas, this is especially pronounced, as a lot of nurses have either left or have become travelers. I was on one of my rural rotations and they had 4 available L&D nurses. And then all of a sudden they only had 2. And I was like, wait, what happened? We just admitted 1 person. And it was because one of those nurses went into labor. And so she was not available and another nurse was taking care of her. And so we now had 2 nurses for our 2 laboring patients. And we had to send another patient somewhere else essentially, because there were 0 L&D nurses to take care of her. Right. So kind of next question. How could the transferring provider maybe set clearer expectations for the patient? Anyone have any ideas about that one? Catherine Dreyer.
They could have had a discussion before sending her, explaining why she needs to go to a higher level of care, and also kind of saying, this is what you're, to expect when you get there. This doesn't necessarily mean you're going to deliver. It's just that we don't have the resources to take care of your baby at this gestational age. And if you needed a blood transfusion, given your history, we could not give that to you. So just clear communication. I don't know what was said, but
sure. Yeah. I think a lot of times patients, they're hesitant to be transferred oftentimes. And so I feel like sometimes when they arrive here, they've been kind of emphasized how important it is that they go, because it is. But I think sometimes they interpret that as meaning this is so serious, I have to be transferred, ergo I will be delivered. And sometimes when you have to pump the brakes because they're no longer bleeding, and they're otherwise stable, that's a surprise for them. I feel like one thing that we can do a better job kind of explaining to them too is the magnesium management. People do not like to be put on nag often, and it takes a lot of convincing to do it. And so a lot of times you have to really emphasize how important it is to the patient. And then when they no longer need it, they can kind of get a little bit confused by that and be like, whoa, 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 some other person just a couple of days ago, a couple of hours ago said this was critical. And now you're saying you're not going to give it to me anymore. And they can become very attached to the magnesium. And so that's just one thing I feel like we run into on L&D. All right. How do we think that the accepting team could improve their communication with each other and the patient?
I just want to echo kind of what you were just saying about in like discontinuing magnesium. I feel like we often counsel patients about why we start things, but we don't often talk about why we stop things. And so I think setting expectations for like timing and what we're looking for and providing some reassurance, but also discussing like why we're being cautious and the benefits of continuing things, even in the context of like maybe no longer having bleeding or labor stalling, I think is important. So like really giving a clear picture as to why we would continue things that the outside provider had recommended.
Dr. Hartenbach.
One thing I think that's really important when we work in teams, and I think of the regional facilities and all the doctors in the region as sort of part of the team. And for me, it's gynecologists, it's medical oncologists, it's a whole bunch of people in this whole catchment area, which you outlined, which is for our perinatal patients, but also for all of our patients. And I think that one thing that can really help is asking the patient what their doctor said, what other people have said, because we're always doing a lot of cross covering. But I think that, finding out, well, what did your doctor tell you about this situation? And then you can anticipate some of these conundrums that they have, because I think it is our responsibility to help support all the people on the team, and we just have different roles to play. And that's true between the specialists and subspecialists in the department. It's true with all of our referring providers and all the facilities. So that's sort of, what did your doctor tell you? I use that all the time to try and understand where the patient's coming from, because that's what we need to meet and understand.
I think that's a really good point.
It's a little bit different for me because I'm usually seeing somebody outpatient and it's a little bit different. But I find it's helpful sometimes to call their doctor and tell the patient, like, I'm going to call your doctor and talk with them. If what they were told is something different than what I'm going to recommend, I'll call the other doctor because they know their patients really well. And there's often often patients don't hear what we intended to say. So there's also that part of things, but that really makes patients feel better if you say, I'm going to talk with your doctor and we're going to make a plan together and then I'll come back to you. I have found that to be helpful, but it's obviously, I have the benefit of it not being urgent.
And I guess I would throw out there, I don't want to speak for Scott, but I would take that phone call any time of the day or night, day, week, anytime. Because we get so little feedback sometimes from the transferring or from the facilities outside. Sometimes we do get feedback. A lot of times we're just reading it from the notes, but if there's a phone call, I will take that phone call anytime, day or night. And we really appreciate that. I feel like when that happens, because we kind of feel reassured. We know our patients are getting great care here, but we feel reassured that that particular patient who I have spent hours with and now is having this event is getting personalized care that I can discuss with her when she gets back as well. So thanks for that.
One thing that I think would make that communication better is that I'm always in that situation where you want to be able to call a referring provider. We'll get referrals that we're looking through and trying to determine if that patient needs to come, how urgent is it. But the referring provider's phone number is usually just an office. And you call back and maybe they're off or they're on vacation, they're in with a patient. UW has an access center that you can call and they're going to page that provider at any point. So I don't know how to fix this, but it's just something to think about. Like, it would be great to be able to pick up that phone and be able to get a hold of the referring provider relatively easily. But that's actually something we struggle with, because there are times I'd love to make that call, but it's like, oh, I got to leave a message or, it's just tough to connect.
This is Christy Troutman. Can you hear me?
Yes.
Hi, everybody. It's fun to hear everybody's voices. I'd like to circle back to, expanding and improving on the communication piece with our patients. And I feel that I have this benefit now when transferring patients to say, you're going to a wonderful place with people who I shared training or who trained me, and I have absolute trust in the care they're going to give you. And I think as the referring provider, it's so important to express that trust in where you're sending somebody, and then definitely explain to them that the plan may change and very likely will change when you get there. And that's okay. They're going to change our plan, and we need them to change our plan so that you receive the care that is of a higher level when you get there. And that some of the plans we make and some of the treatments we start now will change when you get there because they have different capacity to take care of what is our problem. And so from the referring provider's perspective, I think the onus is on us to make sure our patients understand that plan may change. But then also as you receive that patient, because I've been in those shoes too, just like Dr. Hartenbach said, it's so important to include all of the players on the team as teammates and making sure that we all provide support to each other. So when you're talking to the patient as you receive them, even if the plan is completely off the wall, to say, yes, I'm going to talk to your doctor, or I understand what happened there, but here's how we're going to change the plan on your arrival. And just like Dr. Hartenbach said, including everybody as team members becomes so important because the patients feel very cared for in that setting, and we know they're getting great care, but then they can feel that great care. So that's just my 2 cents. Thank you.
Taking notes on some of that dialogue to use when I go to my outlying rural hospital soon. I think that's going to be very helpful. Does anyone have any other comments on this case before we kind of move on to the discussion questions? Okay. All right. So I kind of send these along in advance. And so obviously most of them are for our panel members, but obviously if people have any other kind of comments or questions, I'm kind of hoping this will become a dialogue. So, all right. So maybe you can tell us a little bit about a misconception you had about rural hospitals or transfers before you became a provider in rural settings.
I think when I started my career, I never imagined I'd be at a rural hospital. I remember as a resident, a relative of mine was pregnant and she was going to go to this community hospital that did about 187 deliveries a year. I said, my God, go to a tertiary center. Are you crazy? And of course, I was on the staff of that 187 bed hospital, for 18 years after that, not realizing that you could get good care in many different places. I always think back to my exposure to rural hospitals was first in residency. We used to send residents and nurses out on maternal transports. And I remember getting out of the back of an ambulance, sort of cool with lights and sirens and stuff. You get out and we went to the ER. And I think that the labor and delivery staff was in the ER. I think the patient was there. The nurses were there. I even think the attending was there. When we got out of the ambulance and we started walking towards them, and the look of relief on their face was crazy. And I remember thinking, I'm a second year resident. Do you guys know this? What are you expecting from me? And it wasn't until years later that I understood what that sense of relief was. When we transfer for a patient. But my feeling about rural hospitals was that the medical care was whatever. And having come from Chicago and coming to rural Wisconsin and Waupun, we have a lot of really great providers. We have an MRI machine and we have ultrasounds and we do biophysicals and the things that I really thought didn't exist really do. But when I first came to Waupun 19 years ago, we didn't have a pediatrician on staff. So some of the misconceptions I think are quite true. But the level of care you can get at the hospital is so much more than I had imagined. Good docs, good equipment. Really, I think we deliver good quality care.
Yeah, just to brag on you because you won't do it. One thing I was shocked about when I went to Waupun is how incredibly low the C-section rate was. And admittedly, Sure, we get more complex patients here who've got more risk factors, but even just for like nulliparous, like term singleton vertex deliveries, I can't remember what it was, but it was so low. You remember what it was?
You know, last year was my last full year in practice, and I felt bad because we did about 165 deliveries a year, and we had 4 primary sections. 2 were breaches who went into labor because they and declined a version. One was a previous field trauma, and the other got to complete and refused to push. Now, that was random, 4 out of 165, but it really does speak to the fact that, you know, it may not be what you expect when you go there. This year's not so good, but low numbers, statistics, it's sort of cool.
Yeah, it's a good way to go out.
I can throw out there, when I was in residency here, there was, and I don't know if that's still a thing, but there was one particular hospital that we all would just like roll our eyes and train wreck coming in on a Friday afternoon. And it was always this one hospital. And so then I just assume all the rural hospitals were like that, right? So I think that was my big misconception coming from here and going straight to rural was that it was all just kind of like that. But I ended up on this path basically because the location was a nice place for where both my spouses and my families were. I was like, oh, it's still close to Madison, but I could get more surgery. So I did not have a sense of exactly how it was going to be, but most of my kind of conceptions or misconceptions came from one particular hospital that was having a rough couple years when I was in residency. And then I just assumed everything was like that. The other experience I had was in La Crosse, which was amazing. I wanted to do more surgery. When I was in residency here, laparoscopic hysterectomies were like just being a thing. So I did not really feel like I had great ability to operate on my own after leaving here. So I thought, well, maybe I'll go to a rural place where I can just go and do hysterectomies all day long, because that wasn't available here with, you know, multiple residents and a newer procedure. And I go to La Crosse and like, everybody's smiling. They all look like 10 years younger than their stated age. The OR started on time. They talk to people in the hallway. Like, I'm like, what is going on here? And they truly like, you know, and La Crosse has, you know, I think Gyn-Onc went out there. I don't know if that's still the case. So, I mean, it's not like it was super rural. But I really got the experience of like, wow, there's like hospital life outside of a university setting. And it was like crazy, right? Like mind blown. So I kind of got that inkling of like, wow, like these people talk about like what they do with their kids after hours, and they like leave at 3:30. And so I had these like 2 very differing conceptions of what rural medicine was. And I think we are really colored by those things that we see in residency that we may or may not think will affect us long term. They actually do.
Hey, it's Troutman again. I agree and reflect with what both panelists have said already, and that when you're training and you're in residency and you receive a lot of transports, you develop misconceptions, I think, about where they're coming from, but also why patients are transferred and what you're capable of taking care of at your upper level center. You become really used to, and that becomes your normal. And so you think, how can this not be managed by an outlying center? Because it seems so straightforward. And, you know, as I've practiced in a couple different settings now, it's as you leave residency and you start to experience the world, you realize that just like what everybody has said, not all centers are created equal, and not all rural places are created equal, and not all academic centers are created equal either. And so it really becomes about what you're capable of delivering, the capacity of the blood bank and the place where you land, and nursing staff and partners and surgery teams and all of those things. And so it really is fun to expand where you practice and learn about different places, and you know, get rid of those misconceptions. And then when you are on the receiving end, you're able to understand a little bit more about why those patients come to you. So I think both perception or both viewpoints are really important.
Dr. Spencer.
Something she mentioned, just harking back to that case, we talked about prematurity, we talked about blood supply, but there's a window where you can safely transfer a patient. And I can't miss that window. When the residents come with me, I always try and predict when a patient's going to deliver. And I encourage them to do the same, because when I look at a patient who I might consider transfer, I think, well, how long is her labor going to be? Can I safely get her into an ambulance and get her an hour away? Because I'm responsible for that. It's not like the good old days where those people hop out the ambulance and now they're in charge. I'm responsible that hour. And if she delivers it, or if she makes cervical change from 1 to 2 centimeters, that's enough for me at 31 and 6, because if she's stable, if she makes change from 2 to 3, is that bleeding because she's abrupting, or is that because of cervical change? And I can no longer say she's stable for transfer and do that. Even when we do transfer, I counsel my patients subtly. I say, so look, you've only had 3 contractions this past hour. I'm going to give you a shot of terbutaline that's going to make your heart race, and maybe you'll have 1 fewer contraction. But if you do have a contraction, just if it's not a big deal, don't say much in the ambulance, because they're going to pull off the road and they're going to go to Columbus halfway here, and she's no better off than she was at my place. So, so on one hand, they're totally stable. On the other hand, yeah, I gave them some turb just in case they have a contraction or two, because those folks will pull off the road. The thing that's so significant is, at our place, the cavalry isn't coming. Okay. At 3 a.m, the rapid response team doesn't exist. If the ER is crowded and you call for a rapid response, nobody comes. I think back to a time where a couple of years ago, we had a chronic hypertensive, sort of compliant, sort of not. She was doing fine and called me with a headache. I sent her to labor and delivery. And the nurse sized her up, said, let's just put you in a labor room. I didn't even have her undressed. Said, just lay down. And she hit the bed and she seized. So we have these really big labor and delivery rooms, and they centralized the panic button nowhere near the bed. So the nurse has a patient on a bed with no rails and was like on top of her trying to make sure that the patient was safe, but she couldn't call for help. And she finally, there's a lull, she hits the button, and the cavalry does come, but our cavalry is the ER doc, a couple of ER nurses, lab, I think radiology, and the nursing soup. So they called me, and now I've got a bunch of people with a seizing patient, and I said, just tell them to treat her like a seizure patient. Because they're going to try and start MAG, right? So I get to the room about 10 minutes later. And when I walk in, the ER doc, who's amazing and terrific, and you want to take care of you, looks at me and says, oh, thank God you're here, Dr. Hansfield. And he walks out of the room and everyone follows him. So here it is. We have a post-ictal patient, and it's just me and the nurse. There's no one else. So one of the reasons for being so enthusiastic about these transfers in that patient is, if she delivers, or if we have a problem, there's no one around. There's no one in the nursery. I mean, the nursery is our storage circ room, right? So there's no one there. So when that baby comes, I now have 1 labor and delivery nurse for a patient who seized, and a baby who's not going to be transferred for an hour or 2 based on logistics. So it is one of those things that we take into consideration as we're looking at these transfers.
I think that's really good insight.
I just also want to say I'm a family doc in Boston, and that we also have to pay attention to like the weather here in Wisconsin. So if we know that there's a big snowstorm coming, we may transfer patients earlier rather than later, because we may not be able to get any help in if the weather changes.
With COVID, we had to wait 3 or 4 hours for ambulances. It changed the dynamics tremendously. So you got to figure that into your time of your delivery time is if you do make progress. So usually we have 20 minutes, 30 minutes. They're in our ED bay, and during COVID, about 3 to 4 hours for an ambulance. So, but if they're not stable, then you can't transfer them. So theoretically, they should be stable for 3 or 4 hours.
First, Maddie, you know you've given a good talk when you get through 5 slides in 45 minutes. So you're doing something really well. And if anyone needs a family doctor in Boston, Dr. Kovach is the best one. So go to her. I would say wherever there's misperceptions, there's also true perceptions. And so I've only ever worked here, but I get a lot of opportunity to talk with rural physicians and talk about rural programming and meet with different hospitals. And so I think the reason we all laughed at Dr. Glockenspiel's assertion that this is a dump is because we see in ourselves that feeling. And I certainly do that too. And so within that misperception is the idea that people who are creating clinical programs or training programs in rural places are then doing so to try to get patients to go somewhere else and send them away, where the true perception is exactly the opposite, where they're doing so and working there for the express purpose of wanting to keep as many people all the time in that place as they can. And transferring a patient is a last resort that they don't want to do, because there are also reasons people want to live in those places and get care in those places because they don't want to come here and they don't want to drive into the city, even though this is not necessarily a big city. But that's the true perception, is that they're constantly working in these places to not send people elsewhere. And I think that is what's been really helpful to me, is to come to see and understand that.
We have a question from one of our rural residents.
I think another thing that's important to consider about our rural transfers is that when we get them from 2 hours away, sometimes those patients came to the rural hospital from 2 hours away. And so I think we think geographically that people just hop in a car and come here, but in actuality, like someone virtually said, patients are driving through a snowstorm an hour and a half to get to their local hospital to try to have a baby. And so then, or to get any care that they need really. And so then to say, to have them come here, we're dealing with social stressors and economic stressors for patients who now are 3 to 4 hours away from home, 3 to 4 hours away from their support, in a higher level of care, yes, but also so far away from their network. And, you know, it's just, there's other variables outside. And so like that access to care piece, we are even farther away from where they seek the most of their care. And so that just sort of adds another level and another complexity to things. And so just particularly for OB, and then you kind of go down the tier of, if you're going to offer OB, then you have to have an OR, then you have to have an anesthesiologist, like all of those things. And that's getting more and more pulled away from our like far off rural areas. And so it just is a kind of a complicated trickle down effect leading to these people who show up here and we say, oh, gosh, why are you mad that you're here? We're giving you the best care, but there's so much more than what's happening in that hospital room over on the 3rd floor or 4th floor. So.
Totally. Thank you. Yeah, I think that a lot of times we think a lot about the logistics and specifically like the healthcare component of things, because obviously that's critical. And we don't often stop to think like, why would a patient be unhappy to be here? We're great. But you bring up a really good point. And I think that your rural training will go very, very well with that insight. So, all right, we have just a little bit of time left. So maybe we'll move on to the next question. Dr. Siomos, you mentioned a little bit earlier about, you know, laparoscopic hysterectomy being something that was kind of newer when you were in training. And I wonder, you know, if you or Dr. Hansfield or Dr. Rotman have anything to say kind of in addition to that, or any other kind of aspects you wish had been incorporated into residency that would have prepared you better for rural practice?
I think that the technical aspects of OB were great. The knowledge parts of things in OB are great. That foundation is fantastic. Because you're just not going to see things as much in rural low volume places as you are out here. So that was amazing. NRP, like neonatal resuscitation, kind of scared me, still kind of scares me, because I don't have pediatrics and family practice in the, can be downstairs if they don't have the day off of the hospital, but otherwise they're like 20 to 30 minutes away. So if you're anticipating something, it's easy to call somebody in. Dr. Hansfield like never calls anybody in, but we did, we both shared the same pediatric group for a little while at both of our sites. And now where I am now, it's family practice, and they're very well trained in NRP, but that small kind of once in a while when everything looks great for delivery and then the kid comes out and is not breathing and you're like, oh shoot, that's me, you know, me and the nurses, but me. That would have been a little bit nice, but otherwise like the technical, especially for OB, the technical training, the knowledge training, you will be very, very well prepared for coming from here.
I agree with that. It's like, instead of taking neonatal resuscitation, I learned it. There's a big difference. And then just the nuts and bolts. Our patients don't want to be transferred. You know, when I was at a bigger hospital with a level 2 nursery, you know, I see higher risk patients now in Waupun. My chronic hypertensives want to deliver close to home. My diabetics don't want to drive. It's like, are you kidding me? And so I would say I take care of sicker patients potentially in Waupun. Gynae was the biggest. That's where my in current day my skills are lacking because I never learned vaginal support procedures. So you know, your nuts and bolts. The most patients I transfer away are my gynaes. Vaginal support procedures. I did learn slings. One of the urologists at the hospital I was at before I came here taught me slings, so I could do slings when I got here. But that's it. We'll still always transfer for onc, but learn that extra level of support procedures if you can, because that's everything now.
Dr. Troutman, I don't know if you have anything to add.
I would like to reflect what both of them said, except I think I'd like to emphasize what Effie said, which is you will be very prepared coming from your program to go out in the world wherever you want to go. Several of my co-residents from my class and I chit chat about that on a somewhat regular basis, how grateful we are for our incredible training, because the foundation is so strong that when crazy things happen, we have a lot to draw from, even if we haven't seen that exact thing. So I think you can feel really excited that you're being trained where you are and how applicable that will be both at big centers and in rural places. I agree with all the panelists that you should jump up at every opportunity to learn procedures and enhance your sort of fly alone skills. So if you can find opportunities to do things with little assistance so that you can prepare for flying on your own, that is a big piece of being in rural practice. Just like everybody has said, you are on your own a lot, and NRP is a big deal. And we do find ourselves running NRP more than we anticipated in training, certainly more than I anticipated in training as well. And actually, I got out in the world and needed to do circumcisions, which I hadn't done in training, but learned those quite quickly as well. So I think we're just always learning, and you have a good foundation.
All right. Well, I think that is a very encouraging and optimistic note to go out on, unless anyone has any other questions. Oh, yeah.
Want to call out Dr. Hansfield. Dr. Hansfield and I cooked up the rural residency program about 9 years ago, and his site has been, you know, sort of like the guiding light. And I think getting that experience and knowing what it's like to practice in these hospitals was one of the guiding principles. I remember back to medical school and spending a month in a small hospital in a rural setting, and it impressed upon me how different it is. So I just want to say thanks, Maddie. I want to say thanks to all of the panelists. It's great to see Effie. It's great to hear you, Christy. And, you know, if I could say anything to all my colleagues at the larger centers, you know, when When people call to transfer, they want help for their patient in front of them that they care a lot about. And so my philosophy has always been to say, yes, I will help you. It's getting increasingly hard because of our access problems. But I think we always want to go with that guiding principle that we're all playing different roles on this team, and our referring physicians in different centers have different obstacles, different challenges, but they're trying to do the very best thing for the patient right in front of them, and that we all want to be doing that. So thanks, Maddie.
A big thank you to our panelists.
For the residents, if I can throw out a quick plug for rural medicine, like keep your eyes open. Like honestly, you can't beat 10-minute commutes, like good education systems in Wisconsin. Like my kids have learned how to live through, have been exposed to a variety of different people, not just people that make six figures all the time and kids that go to Europe. I mean, it has been very eye-opening to be in different parts of the world during these or different parts of Wisconsin during these changing times. And I think particularly for younger docs, you get a lot of great volumes in the rurals. The call might be more, but the chance that you actually get called in is a lot less. So I spent a lot more time with my kids than I was expecting to as a full-time physician. I got paid more. I had a bigger house, but I also had more time with my family, which was like the most important thing to me, and got a lot more surgery cases on my own than I really ever expected, because there was just a huge need for OBGYNs in rural places. So thanks.